Hi, this presentation is on the basics of the interscalene nerve block. In terms of our outline, firstly we're going to go through the indications for an interscalene nerve block, then move on to some applied anatomy, how we do the interscalene nerve block, and then look at the side effects and complications of an interscalene nerve block. So one should think of the interscalene nerve block as an excellent block to serve shoulder and upper arm surgery. It's very useful also in combination, so you can combine it with a cervical block for clavicular surgery. You could combine it with a PEX block to fully cover PPM insertion. But the main thing to note about the interscalene block is C8 to T1 is spared. So that is the medial aspect of the arm cutaneously and the medial aspect of the arm in terms of the osteotome. You really need to be wary of the limitations of this block as well. So the interscalene nerve block is really a root block, and it is a root block of C5 and C6. So we can see from this lovely illustration, which is from Asra.com, references are in the last slide, we can see that the brachial plexus is divided into roots, trunks, divisions, cords and terminal branches, and the interscalene block is right up at the top, is at the root level, blocking C5 and C6 as already mentioned. And it's important to do it high up as the nerves that supply the shoulder, and especially the cutaneous supply to the shoulder, comes up very proximally in the brachial plexus. So here we can see the roots C5 and C6. They leave the vertebra of C5 and C6. You can see them here emerging in between scalenus anterior and scalenus medius. The sternocleidomastoid muscle is cut away in this illustration. We can then see the brachial plexus travels down in close relation, superior and lateral to the subclavian artery, passing underneath the clavicle, here cut away, to then cross the thorax again in close relation to the artery, to then enter and supply the arm. If we were to take a cross section at the level of C5 and C6, we would see the following structures. So we can see in the middle of the screen, in between anterior scalene and the middle scalene muscles, we can see our C5 root and C6 root, which is split. And around it we can see several fascial layers, and these are the fascial layers that when using non-ultrasound people used to rely on in terms of the pops and clicks of the fascia. Now we can see that there are several structures that are close by. We have our phrenic nerve from our cervical plexus that usually sits on the belly of the anterior scalene muscle. We have our vertebral artery, which is in close relation to the most deep aspect of the brachial plexus at the interscalene level. Medially or anteriorly, we can see the vessels that supply the head and the neck. So we have the carotid, the internal jugular and the vagus nerve, which is within the carotid sheath. We've also got the cervical sympathetic nerve in very close relation to the interscalene plexus as well. So when we block C5 and C6 in the interscalene nerve block, what effect does that have? So we can see here that C5 and C6 go on to form the superior trunk of the brachial plexus, and this goes on to mix with roots from or nerve supply from C7 at the division level, which then goes on to form the cords and the named nerves. We can see that the long thoracic nerve is given off by C5 and C6 very high up. The long thoracic nerve travels within the belly of scalenus medius, and we can see that the other important nerves of the shoulder, the suprascapular nerve, the subclavian nerve, come off relatively high also. So how do we go about doing the interscalene nerve block? So as for any nerve block, the patient should be fully monitored. So that is EKG, blood pressure, CO2 and saturation monitors as per ASA guidance. We should use sterile gloves and sterile prep, whatever you have available. There should be IV access and sedation if using that. And the needle choice for an interscalene nerve block is a short needle. So 5 centimeter 22 gauge short bevel is best, or whatever needle that you have is the shortest length. Probe, we use a linear transducer, 8 to 12 megahertz, and the volume typically used in the interscalene block is 10 to 15 mils of local anesthetic. So here we can see the position for the interscalene nerve block. We have the patient supine, semi-recumbent, head turned away from the side to be blocked, with the pillow underneath the head off to one side to allow access behind the shoulder. We have the ultrasound machine located on the opposite side of the patient. This is an in-plane technique with the operator standing towards the head of the patient in line with the probe, which is then in line with the ultrasound machine. Here's another view to show you where the hand positions typically are when doing an interscalene block. So you can see here for a left-sided interscalene block, the right hand, which is needling, is fairly posterior, laying on the shoulder and the posterior aspect of the neck. So really any position where this side of the neck is allowed to be free will support the proper conduct of an interscalene nerve block. So equally, you could have your patient fully lateral, or again propped up on a pillow, just as long as that posterior aspect of the posterior and lateral aspect of the neck remains free. So in terms of the sonoanatomy and scanning for the interscalene nerve block, we can see here, as we mentioned before, the brachial plexus remains in close proximity to the artery. So superior to the clavicle, this is the subclavian artery. Inferior to the clavicle, this is the axillary artery. And so we can see here, people often talk about the classical traffic lights of the appearance of the brachial plexus in between the scalenus muscles. However, it's probably more useful to go to a more consistent anatomical location between patients, which is the supraclavicular view. So in the supraclavicular view, which is circled on the left, we can see the subclavian artery passes in the middle third of the clavicle. Excuse me. And we can see the brachial plexus is located superior and lateral to the subclavian artery. We then, after identifying the plexus at this level, then follow the curvature off the neck cephalad, and we begin to appreciate the brachial plexus at the interscalene level. Here we can see the corresponding ultrasound images as we move from the supraclavicular image on the left up towards the interscalene image on the right. So here we can appreciate the sonoanatomy of the neck at the interscalene level, looking at a much broader view, and we can use these structures to identify if we are too medial or too lateral, and we can see how all the different structures lay on top of each other. So here we can see the ultrasound image. To the left is the medial anterior aspect of the neck, and to the right is the lateral posterior aspect of the neck. The corresponding surface anatomy is in the illustration below. So we can see in the middle we have our brachial plexus circled in yellow, and that is sandwiched here in its typical position, which is between the anterior scalenus muscle and the middle scalenus muscle. We can see the C7 vertebra and the transverse process. We can see that there is no anterior tubercle in the C7 vertebra, so we can see a rounded appearance towards the anterior aspect of C7. As we know, bone does not permit ultrasound images, so we can see a hypoechoic shadowing beyond the C7 vertebra outline. We can see the important vessels are all located medially or anteriorly to the brachial plexus at this level. We have our carotid artery, internal jugular vein, and then we have our vertebral artery and vein exiting from the anterior aspect of the C7 vertebra. The muscles we see in cross-section are the sternocleidomastoid muscle, levator scapulae at the lateral posterior aspect of the neck, and the longus colli muscle. These muscles may or may not appear as distinct structures depending on the patient. So here we can take a more focused view to look at the anatomy at the interscalene level. So this is a very typical sonoanatomy image at the interscalene level. We can see that the brachial plexus sandwiched between the anterior and middle scalene muscles. We can see that C5 is the most superficial structure and C6 is bifid. We can see a sheath that's surrounding both of those, which we will need to penetrate for an adequate block. And we can also see some other important structures. So we can see C7 in the deep part of the sonoanatomical image there. And we can also appreciate the dorsal scapular nerve sitting within the middle scalene muscle. In terms of differentiating when live scanning between what is a bifid C6 and what is a C7, that's where we use our depth on our ultrasound machine to appreciate the nerve roots as they move into the vertebral column as we move more cephalad. So with the C7 vertebra, there is no anterior tubercle. So the nerve root that dives into the vertebra at the C7 level, or the level at which the vertebra has no anterior tubercle, is the C7 root. Superior to that will then obviously be C6, and then superior to that will then be C5. So here are some tips to allow for successful scanning of the interscalene roots at the interscalene level. So some of these we've covered already, but we'll go through them again for clarity. So as we've discussed already, the C6 nerve root is bifid, and it's often confused and it was often misnamed as C7. So it's important to know that graduation of knowledge has occurred, and we need to be able to differentiate between C7 and the bifid C6, and we do that, as we've mentioned, by correlating each of those nerve roots to their vertebral level. The next tip is to do slow scanning when dealing with the interscalene nerve block. So all of these structures are very shallow, they are very close proximity to each other, and so with slow scanning you can appreciate them moving in relation to each other. Even pressure, so we can appreciate if there are any anomalous arteries or veins, and probe tilting, which will allow you to follow the curvature of the neck, can more accurately show the sonoanatomy of this area. Like we've already said, imaging the vertebra allows us to ascertain which nerve root we are indeed looking at. And if we lose our way, then to return to the common place with less anatomical variation, which is the supraclavicular view. It's often easy to acquire, and it, like I said, is a good starting or returning point. Other sonoanatomical variations, we often see the plexus sandwiched between the scalenus muscles. However, the plexus may exist within the belly of either of those muscles, so within the belly of either the anterior or middle scalenus muscle. So it's important to appreciate that that anatomical variation exists. So here we can see the typical needle trajectory of in an interscalene nerve block when approaching the plexus with an in-plane technique. We can see the needle position is at the lateral posterior aspect of the neck towards the medial anterior aspect of the neck. We can see the needle traverses through the middle scalene muscle. If the dorsoscapular nerve is visible, then obviously avoiding this structure. And then the needle is placed between C5 and the bifid C6, which you can see on this image. The fascial sheath can be felt, which surrounds those two structures, can be felt to give as it is punctured. And then when the local anaesthetic is infiltrated, we are looking for movement of those nerve roots away from the injectate to show that the needle has just punctured the fascial sheath and not the epineurium. We clues that the needle is actually in the epineurium would be no movement of those nerve roots and of those nerve roots becoming larger with injection, both of which should trigger immediate cessation of local anaesthetic. So if we cycle back to our earlier image, which shows us the cross-section of the neck at the interscalene level, we can use this to predict all of the interscaling side effects and complications. So the first thing to note is the phrenic nerve lies in very close proximity to the interscalene, to the brachial plexus at the interscalene level. So we can see how any local anaesthetic solution which is deposited between the scalene muscles would travel round and block the phrenic nerve. So in almost 100% of cases, if more than 10 mils of local anaesthetic is used, the phrenic nerve will be blocked. Whether this causes clinical dyspnea or any clinical side effects is very patient dependent. The other side effects are from local anaesthetic. So the other complications are from the local anaesthetic going to all of these nearby structures inadvertently. So the carotid and internal jugular would obviously cause high bleeding, and because of their proximity, close proximity to the brain, would give you a very high incidence of LAST if there was intravascular injection. The cervical sympathetic chain is nearby also, and spreading of the local anaesthetic at this level would cause a Horner syndrome. The vertebral artery, if the tip of the needle is not visualized and too deep, an inadvertent deep injection is given, we can see how stroke could be caused, how we could again get LAST, and a total spinal if the needle actually traverses the dura at this point. It is very rare, but pneumothorax is also feasible. So I hope you found that introduction to the interscalene nerve block useful. Here are the links to the references used for the illustrations in this talk. I hope you go on to explore these websites further.